Well, first of all, let me say thank you for being here. As John mentioned, what you have been doing in this arena and many others has been absolutely phenomenal. So I know we have 20 minutes. So let me ask you to begin with, just give a little overview of the Health Access Initiative as part of the Clinton Foundation, because I know the maternal health is a component of this, but just for everybody here who may not be as fully aware, just a little overview.
Well, Michael, thank you so much, and thank you to Aegis for hosting us in this extraordinary place. It feels quite fitting to have conversations about health and what was once an abbey. The genesis of the Clinton Foundation really was when my father was getting ready to leave the White House, contemplating like where to direct his, thankfully still kind of rather enormous energy and capacious brain and heart and ecosystem to still hopefully continue to make a difference. And one of the areas, and he has said this publicly, so I'm not casting aspersion here, that he really felt where he had not done enough was on the global HIV/AIDS epidemic. Casting our brains back, in the beginning of the millennium, only about 10,000 people in sub-Saharan Africa were on antiretroviral medicines, although the global AIDS burden had kind of more than crossed 20 million, and most of the patients most in need were in sub-Saharan Africa. And so my father, with Nelson Mandela and some others, as he affectionately called them, formers, decided to think about how could they help take what had been historically a high price, low volume market and invert it into a high volume, low price market. So fast forward, what had been about $10,000 per person per year dropped to about 120, and then 90, and now it's $60 per person per year for first line ARVs and close to that for second line ARVs. And so of the just under 29 million people in the global south who take ARVs every day, to hopefully enable them to die of other things than AIDS, about 80% of them access their medicines through agreements the Clinton Foundation negotiated. So that type of kind of market shaping work of kind of bringing together the public sector, the private sector, the NGO community, the philanthropic community really has then become kind of not only the ethos, but kind of the strategy of the Clinton Foundation since. So we've negotiated more than 140 agreements, lowering everything from point of care diagnostics to supplemental nutrition to ORS and zinc to here in the US, naloxone. And I'm incredibly proud to be a small part of this effort, and also to really focus on maternal health, which means a lot to me, particularly as a mom of 3.
So on the maternal health issue, what is happening that you're positive about? And then what is it you wish that would happen that is not happening? Because we've got a lot of different systems here from different parts of the country, and collaboration and partnerships are important. But what's good? What is the next step?
So I'll start on a global level, and then I'll talk about the United States. So on a global level, the Health Access Initiative, with many other partners, has been part of helping to kind of drive down maternal and infant mortality around the world. But now, candidly, we're stuck. And we're stuck for a few reasons. We're stuck because global health funding has largely flatlined. We've reverted back to the pre-COVID levels, which, while they increased dramatically from kind of 1990 to 2015, had then largely been stagnated. Got a big kind of infusion during COVID, but now have retreated back to kind of the level of inertia. And so that means, thankfully, we're able to continue to support governments in the priorities that they had already oriented around infectious diseases, but also tackling maternal and child mortality and morbidity in a certain set of strategies. But now, for example, what we really need is like medical grade oxygen, right? All of you work in hospitals where probably if you asked your doctors and nurses, where does oxygen come from? They'd say like out of the wall, That is not the reality for most people in the global south. It is, though, a challenge we actually know how to solve, but we don't have the resources to do it. And so I'm optimistic because we've made enormous progress. And to me, that just continues to prove that progress is possible, kind of when you can marshal the right people around the table, kind of with the kind of right time horizon to help tackle those challenges. But I'm also keenly aware of where we haven't yet succeeded. Here in the United States, I find it, so challenging that even before the abortion bans, I was 50% more likely to die in childbirth than my mom. That to me is just an unacceptable reality. And of course, as Michael, thankfully, because as we heard in kind of John's introduction, like you have made this a priority, at Northwell. We know that reality is, far more dangerous for Black, brown, and indigenous women who are pregnant or who have recently given birth. I find it challenging that this isn't more of a national priority, one that should not have kind of political dynamics to it, and yet, of course, has become so political because we've had politicians in 15 states decide that they know how best that your kind of provider should be able to provide care. And so it has to be both activated in settings and systems like Northwell and all of yours, but simultaneously we have to fight on kind of the political field until we hopefully finally remove it from the political field and firmly situate, maternal health kind of as the public health and patient health issue that it should be. So I'm optimistic that we thankfully are having more and more people in this country, slowly recognize that what should be doctor and patient decisions need to reside there and not, in state attorney general's offices or state legislatures or at the Supreme Court. But we still have a lot of work to do.
If you were to list the root causes of high maternal mortality among Black women, which is 3 times that of whites, and actually in New York City, it's actually much more than that.
9 times.
9 times.
We like to think that we're so liberal in New York.
Right.
But yeah, 9 times.
What would you list as the root causes? Because knowing the root causes allows you to figure out where you target. People, there's combinations of different things. What would your priority root causes be?
Oh, goodness. Well, I think, what do I think the root causes are? Well, certainly I think, unfortunately, it is a rather American challenge, right? What we see in the United States in terms of our racial disparities, while certainly we see racial disparities in other high-income countries, unquestionably, we seem to have kind of, uniquely made pregnancy and postpartum dangerous for Black women in America. And so certainly I don't think we can decontextualize that from our history. And yet I think we always have to start where we find ourselves. And so while I think, and there's been enormous amounts of research on kind of the hard-coded, unrecognized sort of miasma of racism that permeates all of the ways in which Black women and Black families interact kind of with public health and healthcare systems, I think we have to start with what we know works. And we thankfully do know quite a bit about what works to invest in early childhood, because that, of course, has long-term kind of dividends for health and well-being, what we need to be doing in kind of the public education system, certainly what we need to continue to support from a public health insurance perspective, what we need to be doing to help kind of recruit and train and retain more Black doctors, nurses, midwives, doulas. I was incredibly excited to see the recent announcement about the new HBCU medical school that will be built in New Orleans. So to me, it's not actually a failure of diagnosis. It's a failure of like intentionality and investment and kind of seeing movement from a kind of public sector perspective, a political perspective, a health systems perspective, a medical school and a nursing school perspective. Like, these are not questions that we don't know the answers to. It is an inability to kind of marshal and sustain resources in the multitude of answers that we know need to be effectuated together to really help better protect Black women and Black families in this country.
At Northwell, one of the two issues that we're working on, among many, many others, one is the whole issue of bias in how we train, how we educate. And the second issue is that we have a very, very sophisticated, and I'm sure others have it here, navigation program, where we are navigating thousands of mothers through the whole process from the beginning to end. And we have demonstrated that that has shown quite a bit of an improvement. And we actually have a research project that we got from the NIH, money from the NIH, to study this a little bit more. Comment on the issue of, you alluded to it, on the issue of bias, physician bias. To what, how, it's things people don't often want to discuss or talk about. They don't want to be openly talking about it, but I think it's necessary to address. And then the issue around the potential of serious navigation. And then let me add a third piece, is technology. To what extent, because there's a lot of technology with kids in the room here, and what is the role of technology that can actually help in some areas, like we're working on the issue of preeclampsia, et cetera. So some comments on where you see this and where you would like to see it move.
Well, I worry tremendously about the question of bias and how it relates to women broadly, and particularly, Black women. As I'm sure, all of you are probably aware, it wasn't until, the NIH Reauthorization Act, goodness, about 30 years ago, that women were required to be included in clinical trials. That means that all the data up to that point probably wasn't representative. It wasn't until about a decade after that that children were required to be included in pediatric trials, which is insane to me as a parent. Like, you just have to think, we've all given Tylenol to our children. There would have been safety signal after many billions of doses provided if that wasn't a good choice, but it's bonkers, not for lack of a better word. And so I do worry about the people who are much smarter than I am in technology, who are building all of these large language models that we are recognizing don't have sufficient data. So now there's like synthetic data that's derived from the data we have is just going to further kind of compress and exaggerate our bias challenges, while actually often with like very noble purposes or trying to be kind of the antidote to the human bias that we see, certainly when it comes to women. I mean, you all are, as I'm sure, familiar as I am with, like, our pain is not taken as seriously as men. It's even worse for kind of Black women who are in pain, even especially actually when Black women are pregnant. And so kind of we have all of these like high vaunted hopes that algorithms are going to help kind of countervail human bias. And I worry actually could inadvertently only exaggerate human bias. And so I do think like those are questions that have to be reckoned with by many of the people in this room and not in this room. And then I think one of the other challenges too, which we haven't talked about yet in this conversation, that I am keenly aware of in my original home state of Arkansas, although I'm a proud New Yorker. I've lived in New York now 20 years. I've lived in New York longer than anywhere else. I'm like raising my kids in like the heart of the city proudly, is that our maternal mortality crisis doesn't look the same everywhere. And so I think one of the challenges is we often have kind of these global conversations that are necessary to hopefully kind of catalyze and sustain the investments we need from the federal government. Certainly, I think that's true. We've seen that certainly to be true when it relates to Medicaid and the ability to cover new moms now 12 months postpartum. Sadly, Arkansas is one of 4 states where the governor has chosen to not do that. But in Arkansas, we see the collision of multiple public health crises that exacerbate kind of the challenge for expectant and new moms, which now has led Arkansas to be 50 out of 50 in terms of maternal mortality. Right? We see the opioid crisis, we see our gun violence crisis, we see our environmental health crisis, all coalescing to make it particularly dangerous to be a pregnant person or a new mom in Arkansas. And then unfortunately, being political, when we have a governor in Arkansas who is not willing to expand Medicaid, Arkansas has some of the most restrictive abortion laws in the country, where Arkansas is not easily accessible to states where you're able to access abortion care, where Arkansas has some of the lowest levels of paid maternal leave in the state. Great if you work for Walmart, not so great if you work in a lot of other employers in the state. And so you see in Arkansas quite keenly how it's not only everything that we've already talked about, with additional, I would surmise, failures on the public and the political front, but it's also a place with still huge amounts of stigma around accessing care. And so you have more babies being born addicted to opioids in Arkansas on a population level than you have in almost any other state. And you have one of the highest rates of maternal violence with a firearm in Arkansas. And so I think we have to have national conversations and also recognize that those conversations can't be completed without kind of the state and the local kind of dynamics kind of also being brought in.
In New York, where we have a particular problem on this, I know you've been quite involved with the city of New York and obviously in part with us as well. In New York, what makes you optimistic about the potential for positive change?
Well, I'm incredibly optimistic because thankfully, I think we have a really wonderful health commissioner in Dr. Vachon, who really has just thrown arms wide open to kind of all partners. I was at the last maternal health collaborative meeting, which had just occurred to me, was at the Trinity Church facility in downtown New York. So I keep kind of thankfully being in these kind of holy spaces for this urgent work. And at the first meeting that we'd had, goodness, maybe 6 months before, we had about 30 partners there, including Northwell. And we had doubled the number of people who were there, from local nonprofit and venture-backed startups trying to expand access to midwifery care, to other parts of the city government, like the Department of Education there being how can we be part of this work, to even more hospital systems, to one of the local logistics companies. I mean, truly multiple parts of the city raising their hands, multiple parts of the kind of New York health and public health community, but also people outside of kind of one of the obvious places saying we want to be part of this too. How have we let it come to be that if you're a Black woman in New York City, you're 9 times as likely to die as a white woman in pregnancy or in the 42 days postpartum?
You have about 11 health systems here from different parts of the country. All innovative, creative, wanting to do new things, interested in partnership. This is the reason for a meeting like this. What do you want to tell them? What would you like to tell them? What would you want them to do?
Well, I mean, they are all better.
They're at your disposal. You're in a religious place. You can command their attention.
We do have a lot of religion in our lives. My husband is Jewish, and I'm a Methodist, and our kids go to Hebrew school on Thursdays. We have Shabbat on Fridays, and I take my kids to Sunday school and church on Sundays. So I'm a little uncomfortable, appropriating the kind of religious pulpit.
I grew up Catholic. I'm okay.
And I was I'm fine. No, I would just say, we at the Clinton Foundation are very much in the business of partnerships. We think we know quite a bit about what can work at scale in the global South, and we've brought some of that work, thankfully, right here at home, particularly in Arkansas and now in New York City. And we also know there's so much more that we don't know. And so I would just say, if there are ways that any of our work could be helpful to you. Like, we always want to do that. And I hope, like, rather presumptuously, if I think any of you can be helpful, like, hopefully you'll take our call or respond to my email.
I have a last question. Now, you're involved, we often think that all uniqueness and good things occur here, but you're involved overseas quite a lot, and there are practices from overseas that sometimes, if we were to adapt them here, some more simple things that if we were to adapt them here, could actually make a dent here. So learnings from overseas to the United States. Sometimes we think that learnings come from here over there. Yeah. Think of it the other way, from over there here. What is it that is somewhat unique about some experiences you've been involved with overseas that might help us here nationally?
Well, I think certainly we've been involved in a lot of community healthcare worker programs, both piloting them and then helping to scale them. And I've never understood like why we don't have more of a community healthcare worker-centered model in this country. I also think we desperately underutilize our public school systems. You know, I went to public school in Arkansas in the 1980s and the early 90s. I had like nifty nutrition came to like teach me about nutrition. Like, we had oral health classes. We had like ear checks and eye checks. You could get vaccinated in school through our local vaccine clinics. I also had age-appropriate, evidence-based sexual and reproductive health education. If I were a public school student in Arkansas today, none of that would be true. And so I just think because we've worked so closely, we've now worked in about 40 countries across the global south, you know, to build what I believe are like the real like bedrock infrastructure of like health and well-being, often through community healthcare worker programs where there is no last mile, like where every person is able to be seen by someone on a moped or a bicycle or by the power of 2 feet, that we should be doing more of that here. And I think we have made, for reasons I don't have time to go into because I see our clock, purposeful disinvestments in our schools as being the engine of like civic and social health and well-being that I wish also hadn't been politicized and that we could once again return to. And I think probably a lot of your health systems are really well positioned to be partners in that if you have the local political environments that are receptive to it.
Well, I know we're out of time. On behalf of everybody, I want to thank you for taking the time to be with us. Thank you for the fabulous work that you're doing. We at Northwell, we work closely with the Clinton Foundation. There's lots of sharing of information, great ideas that go back and forth. So thank you for all the help and the leadership you provide. And thank you for taking the time to be with us today.
Thank you so much, Michael. Thank you so much, everyone.